Hi, everyone. Welcome to the second session of Lloyd's Academy, Asia Pacific, Middle East, and Africa educational program for 2024. My name is Shai from the Market Development Team for Lloyd's Asia, our platform in Singapore. We have a very interesting topic today on the clinical aspects of healthcare risks. Before we proceed, I'd like to introduce our esteemed speakers for today, Stella Timms and Holly Hope from Allied World. Stella is currently the Assistant Vice President for Risk Management at Allied World. She joined the organization in 2023 as the Healthcare Risk Manager based in London, supporting clients internationally. This client focused role provides risk reduction by offering access to a range of patient safety resources, educational materials, and bespoke risk management in response to individual client needs. She is a qualified adult nurse with active registration and over 15 years of experience in the NHS at an Inner London Foundation Trust. Prior to working at Allied World, she worked as Associate Director, Head of Nursing, responsible for the organization's governance, regulatory compliance, and patient experience. Meanwhile, Holly Hope is the Vice President for Europe Healthcare Division at Allied World. She joined the organization in 2020 and is responsible for the underwriting and development of the international healthcare portfolio across both open market and delegated authority business. Prior to joining Allied World, Holly worked for Lloyd's managing general agents specializing in UK and European healthcare business. Such an amazing speakers we have for today's session. So throughout the webinar, feel free to ask any questions that you may have through the comment box at the right corner of your screen, and we'll be happy to answer them at the end of the presentation. This session will be recorded and uploaded online and will be shared upon request. An important note, please remain until the end of the presentation and complete the feedback form to receive your certificate of attendance and claim for CBD hours. And lastly, the views and opinions expressed in this webinar are those of the speakers and do not necessarily reflect the official policy or position of Lloyd's. The information provided is for general information purpose only and should not be construed as professional advice. All right, without further ado, let's get started. And I'm handing over the time now to Stella. Stella, thank you.
Thank you so much. Good morning from London. Thank you for having us here today. So as discussed, we'll be looking at a clinical perspective to risk in the healthcare setting. Just like to say hello to Holly.
Hi, yes, thank you. Thank you very much. I'm here really to provide an underwriting perspective on how clinical risk insights can strengthen client and broker relationships and really support the underwriting approach and results.
Thanks, Holly. So just to talk you through what we're going to be covering today in the session. So we'll look at how we apply mitigation and risk reduction through experts from industry. We're also going to talk about the business insight that can come from risk engineering and risk management, how we connect with our clients using this resource. And then we're going to have a bit of a discussion about how clinicians see risk. So obviously you have an underwriting perspective, and then me being the clinician has a different perspective. And finally, we'll talk about how this impacts and supports underwriting. So just to talk a little bit about what Allied World does in regards to risk managers. So our risk managers are for industry. So we have a large team of risk managers across all lines of business. Myself and a colleague who's based in Hong Kong, Professor Albert Lee, support the healthcare lines globally. So that means all territories apart from the US. We've got quite a nice team, quite a nice mix between the two of us. Obviously, as I'm a registered nurse, I've worked in the public sector, in primary care, secondary care, a lot of different experience in clinical roles, management roles and corporate roles. So a variety of different skill sets. I've done service development, implementation, remodels, consultations, quality improvement methodology, and a lot of clinical simulation facilities. So some education and also improvement work is in my career portfolio. And my colleague, Albert Lee, Professor Albert Lee, I haven't done him justice here, but he is, his business card is like this. He has a lot of letters after his name. He's very established academic. He's a clinical professor at the Public Health University, Primary Chinese University of Hong Kong. He's still practicing as a family doctor. He works with us in a medical legal facility, so he's a trained lawyer. He's also an accredited mediator, chartered arbitrator, and an expert witness. He writes journals, he writes in books, so he's everywhere and he's very well accomplished. So between the two of us, we have a good mix of skills and academia, which we can apply then to client risk. So the kind of ways that we are used as a resource for clients and that we can support clients is really quite varied. So we do our own webinars where we pick topics. This might come from trends, it might come from interest from clients, or it might just be, as you say, like emerging risks and new issues that are cropping up. We create written content. We give scholarships to our clients, which means they get to attend educational conferences with us. So we can sort of structure some learning there. So pick conferences that we believe will give great value to our clients and help them to improve. We offer educational subscriptions. My colleague Albert delivers seminars and we both do conference speaking. So we have a wide variety of ways that we can support our clients. So if I think about my role and what it brings to insurance is really that insight into business. So I think healthcare as an industry obviously works very differently. The people who work within it have certain quirks and ways of being in that world. So I think knowing that gives you a lot of insight, which is really helpful. You might have insurers' outcomes might vary from the client's outcomes. So the insurer might say, okay, well, we want to reduce X or Y. However, that might not always be possible in the time frame. It might be understanding the challenges that the client has to deliver the outcomes that is needed. So it's being able to have that conversation and add to that narrative between the insurer and the client to say, okay, you want similar outcomes, or actually this is the outcome they're going for because this is the impact it will have for their clients and patients. I very much do a lot of translation. So obviously the medical jargon, a lot of our underwriters they're really good at the medical jargon. Actually, they don't know it themselves, but there is still a lot of translation and actually just saying how things work in context. Also an agreement. So I think if you have specific terms to do with your policy, it's getting that buy-in from the client sometimes, because you might have to set terms in a specific way, but actually it's again just being able to translate and have that conversation about how this impacts. We also have clients who are doing really new and exciting things, which potentially could be a positive risk, because there's a lot of risk at the beginning, but as they develop or as they embed something new, then obviously that risk goes away. So that will be a longer term positive outcome. However, in the beginning, there might be more risk. So it's framing that new services, new development to say that this is a risk, but it's a positive one. Smoke and mirrors, we have a lot of our clients and entities, I know from doing regulation work, is people are very good at selling themselves, even in healthcare settings. So we deliver a wonderful service. We're very patient orientated, and everyone wants to put their best foot forward. However, sometimes it's reading between the lines and just working out the client is presenting this picture. Does it match with the information we have? And you can get this information from accounts, reports, information online, patient perspective, as sometimes the clients, you can pick the numbers that you want to represent how well you're doing. Another thing that I think is quite interesting is the leadership culture. So a lot of the meetings that we will be in with clients will be CMOs, CFOs, the people at the top who are running these organizations. And their culture usually filters down into the lower of the organization. So it's really important when you get a sense from the people that you're having meetings with. And you can see if they're orientated around patients or if they're orientated around money or reputation. And I think that has a lot to play in going, is this a good risk? Are they investing in their people? Are they investing in their patients? Because I think if you are patient-centered and staff-centered, you will get good outcomes. And another thing to recognise is system fatigue. So you might have some of your entities, so for example, a mental health entity who has a common issue that reoccurs, and they accept that risk and say, well, you know, it's a high risk mental health unit, we have restraint, this will happen. That might be the case, but you need to know that that the people behind it are not fatigued by what's going on or reoccurring risks, that they're actively still trying to improve on it, even if that's limited. So we can really look into these, look at the information we get and just give that context and narrative, and also ask different questions so that we can understand the clients better. I'm going to pass over to Holly now.
Thank you. So how does this in turn impact how we actually connect with our clients? Currently, we have an extremely broad client base. We have a healthcare portfolio made up of a wide variety of risk types across many different geographies around the globe. And these range from small startup clinics and individual consultant surgeons right through to large multinational hospital groups. So in order to tailor our products and our underwriting approach, it's obviously extremely important that we have a good understanding of clients' challenges and risks from a clinical perspective. So, for example, this may be the risks associated with implementing new technologies, such as a hospital transitioning from paper to electronic medical records. Or it could be the challenges that some of our clients face with staffing shortages, which continues to be a global problem across the healthcare sector. So by having these clinical perspectives, we're able to better connect with our clients. And this could be through the meetings that we have, the risk management conferences that we attend, or the specific risk mitigation programs that Stella implements. I think most importantly, this is absolutely essential for forming long-term partnerships with our clients and brokers, and that really underpins how we operate as a business. So now we're going to look at some examples. Oh, sorry.
No, carry on.
Of how underwriters and clinicians see risks differently and how this can in turn impact the underwriting. So our first example is birthing pools. And I think there's certainly a general underwriting perception in the market that birthing pools are a higher risk activity than a traditional birth. And I think this perception absolutely plays into insurers' risk appetite. And it's driven by various assumptions that underwriters like myself make. And these include, firstly, a view that fetal monitoring can be challenging or more challenging in a birthing pool, which can in turn lead to an increased risk of a hypoxic event for a baby. And these are generally some of the largest claims that we see in our line of business across all different countries. Secondly, we assume that patient selection criteria for water births may vary from one organisation to another, again increasing the risk that higher risk pregnancies may still be deemed appropriate for this type of birth. And finally, we have an assumption that water births are generally led by midwives as opposed to obstetricians, again increasing risk due to the difference in clinical qualification and skill level.
So I have a different perspective slightly. So I can understand why that would be the underwriting perspective, and I can understand actually why most people would think, okay, birthing pools, you know, a little bit more of an uncontrolled environment, a woman in a lot of pain in a big tub of water. So that does seem quite an obvious risk. However, I think things have really, it's all about how you allow that selection. So really with birthing pools it is safe, and actually the evidence now is beginning to say that it's as safe as birth on land, which is what we call it if you give birth on a bed. And that's because it's just about how you make sure you assess your patients for their suitability. So if you're an uncomplicated pregnancy, low risk mother, no problems with the baby, then water immersion in the first stage of labour is actually very, very beneficial. There's less analgesia required. The buoyancy of the water supports the person giving birth, which helps with fatigue. And evidence is showing that actually there's less intervention needed. So this is a reduced need for episiotomies, lower grade tears, and the person giving birth is reporting better satisfaction in the birthing experience. So there's no evidence to suggest that water birth is higher in risk than birth on land based on having the appropriate patient. And recently there was a study in the UK, so it's seven-year study, nearly 90,000 women across 26 organisations, and they actually showed that the babies requiring antibiotics or respiratory support post-birth were exactly the same, comparable numbers to that of birthing on land. The postpartum hemorrhage rates were the same, so that's having a huge bleed post-birth. And then staying in the pool with a midwife present was just as safe as leaving the pool to deliver for the women with uncomplicated pregnancies. So really, this is something that's increasing in popularity. So if you're getting proposals and requests, and we find it with some of our organisations coming through, some don't want birthing pools, don't have birthing pools, and others are quite pro birthing pools, that actually then you need to say, okay, well, it's about asking the right questions about the birthing pool. So what's your criteria for giving birth in a pool? And I think if you have an organisation that has a robust criteria, a low threshold for getting women out of the pool if there's complications, then that will actually be a safe entity, be a safe risk, and it'd be something that you can underwrite with comfort because you know that their protocols are in place. Let's move on.
So our second example is weight loss injections. Most healthcare underwriters will be aware that Ozempic, which is a particular type of weight loss injection drug, has this year officially become the subject of a class action in the US. However, I imagine many underwriters, including myself, don't necessarily have a detailed understanding of the specific allegations made within the lawsuit, and we're likely to have clinical questions around the safety of the drug and questions around whether it's been removed from the market in certain countries. And of course, we're also likely to have potentially an unclear view on the potential for similar litigation to start in other countries. I also believe these drugs may be prescribed off-label, meaning they're being used for a purpose which differs to its original license. So as Ozempic, taking Ozempic as an example, that's traditionally a drug used for diabetes. So the general underwriting opinion of weight loss injections from my perspective is that these drugs may be unsafe, may be prescribed irresponsibly by some types of providers, particularly online clinics, and this in turn makes them potentially subject to abuse by patients.
So I think actually me and Holly actually agree on a few things here. There's a lot behind these weight loss injections. Obviously at the moment, very popular, very topical, and it's now a few countries are beginning to approve it. So the public health system in England and Wales has weight loss programs which the patients are prescribed and using these medications. So I think that gives us a feeling of, okay, well, huge health systems are using them for their patients, so they must be safe. And they are safe if used in the correct way for the correct patient with the correct monitoring. And I think that's the key information there is you end up with big gaps in safety if there's not monitoring, there's not wraparound care, and there's not continued support for the patient. So if we look at the drug in itself as well, as Holly mentioned, it is for type 1 diabetes. Last year, end of last year and earlier on, there was problems with supply chains. So there's a kind of an ethical dilemma there. So if you're underwriting a company who is taking products and medications from people who actually need it to sustain life, is that something you would want to do ethically? I think those things are beginning to resolve now, but at the beginning there was huge issues to the point where some people were concerned they wouldn't get their medication. As Holly mentioned, it's really open to abuse. So we're seeing now that people are going for online prescriptions. And what that means is they'll find an online prescriber. They're putting modified images. So they're doing images of their faces, looking more fuller rounded, more weight on their faces, and they're reporting incorrect weights. And that's so that they can meet the criteria to get the medication. We're also seeing reports that people are doing this to get slim for holiday. So they're wanting to get prescriptions for a couple of weeks to lose a couple of pounds so they can go on holiday, beach body ready. There's also a big black market trade for this. So we're seeing that beauty salons over here are selling it and will sell it to everyone. These people are not qualified to sell these medications. TikTok, Instagram, people are advertising that they can sell them. So again, you end up with a lot of medications in circulation at high risk. And obviously we wouldn't be underwriting those aesthetic clinics, but it's just worth knowing what's going on around these medications. Another thing that's happening is the side effects. So you might have heard of the Wegovy face, which is where you use a lot of fat on your cheekbones and your face, and you end up with a very gaunt looking hollow face, hence the skeleton. So there's a lot of side effects that people are not necessarily ready for, and new treatments are coming out for that. And I think most worrying as well is the mental health aspect. So what we've actually found is the patient information leaflet in the US declares that there are potential risks to mental health. So there's information that it may cause suicidal ideation and depression. However, that is not written on the UK's patient information leaflet. So that's worth considering. So it's not a straightforward over-the-counter medication. It does require a lot of wraparound care. If you were going to underwrite a risk for weight loss, you would want to see it as part of a wider program. So the prescription is actually a tiny part of it. There would be maybe psychological support with diet and exercise ongoing, as the way the medication is meant to work is that it helps you lose weight, but while you're losing weight, you adapt your lifestyle to a healthy lifestyle. So when you stop using the injections, you continue to maintain a healthy lifestyle. Okay.
Okay, so our next example is blue light ambulances. In my view, there's definitely a market perception from underwriters that blue light ambulances are moderately exposed to high value claims, such as paralysis, birthing incidents, or other types of permanent patient injury due to equipment failures or drug stocking issues. I think underwriters accept that generally the likelihood of litigation against emergency care providers is generally low because the scope of services that they're delivering is broadly restricted to stabilising the patient and transporting them. But as patients are in a critical state, when there is clear negligence, clearly any resulting claims have the potential to be significant in value. And there are other exposures that we need to consider, such as coroner's inquest costs due to unexpected patient deaths. So an example of a claim that I've seen in the market is for in excess of £10 million in damages. This is in the UK. And this is where a patient was left tetraplegic, allegedly as a result of failures by the provider to perform the correct checks and to perform the correct immobilisation procedure prior to transporting them. So yeah, an interesting example which kind of highlights why there is this wider perception from underwriters for these types of risks.
So with a blue light ambulance, the person travelling is an individual that has an acute health event, so they require a rapid transfer. Usually there's two ways that this would happen. There would be an unplanned transfer, so that would be responding to a 999 911 call where say perhaps a person is having a heart attack and an ambulance is going to collect them and blue lighting them. Or there may be a planned blue light. So you may be at a hospital that doesn't have a specialist facility that you need, you're acutely unwell, and they need to transfer you to another hospital. In this case, you are a planned blue light, which means you would have already be in a hospital setting, you will be stabilised, and then the fact that you can move rapidly through traffic, you can get there in no amount of minutes, means that actually you're going to get to the care quickly. So the patients are acutely unwell. but usually they should be stabilised before transfer if it's planned. And even if it's unplanned, paramedics will stabilise at the scene before moving a patient. And this is why you also see an ambulance might arrive and they might pull in like a helicopter. So they might get in one of the other types of ambulance or a bigger crew. Also, with a planned transfer, that patient might actually go with a transfer team. So previously, when I worked in the hospital, we would, with patients, depending on their condition, you would also be sent with a doctor and a nurse. So you could actually have more people on hand to care for you during that transfer, depending on what was wrong with you. So they are acutely unwell, but they're going to get to where they need to get quickly. They may actually come with extra support, and usually they're stabilised before they leave. So the risk, I don't know whether I would consider it to be high risk. And actually, when you look at the proportions compared to people who are in a non-blue light ambulance, there might be different risks, but it might actually be worse. So when I think about things that have gone wrong in ambulance transfers that I know from working in the system, is patients who have got an ambulance and fallen and have suffered broken bones. We've also had patients who have dementia, who have been taken to the wrong property, so taken to the wrong house. And so there's obviously implications there. Whether the negligence would be higher as well if you have an acutely unwell patient, what would the impact be? So again, if this patient is acutely unwell, it would have to be quite severe negligence to change the outcome. I think Holly had a very good example there, but is that going to be common, and how commonly would that happen? I also have some contacts who worked for the London Ambulance Service, and just having discussions with them. So commonly they would get claims for negligence from delays. The ambulances are meant to respond to each category of acutely unwell. So they categorise how unwell the patient is, and they are meant to respond within a certain amount of time. And they would get claims around delays to that. Sometimes they don't get there within that time frame, but more than likely it wouldn't go anywhere. And negligence by the paramedics was very, very rare. So maybe not as risky as we first thought. AI.
Okay, so moving on to AI, our next example. AI is not new. We know that healthcare providers have used AI for a number of years. However, over the last 12 months in particular, there has been an increased focus on AI as a potential emerging risk in the healthcare sector. And this has become a consistent topic of discussion with our clients and our peers in the market, whether those be competitors, brokers, or reinsurers. So in terms of its uses, we know that AI has been used for over 2 decades now to run robotic surgical systems, such as the really well-known Da Vinci surgical system. But now we're seeing AI being deployed more broadly in a healthcare setting, for example, to support pathology and imaging diagnosis, and to semi-automate patient documentation, which can actually be a good thing for risk as it increases patient clinician time. So from an underwriting perspective, AI also generates interesting legal considerations around how it's regulated and how that regulation differs between countries, and also how liability may be apportioned between the various parties in the event of the claim, i.e. Apportionment to a tech provider versus the healthcare provider. And of course, there are other considerations that we need to think about, whether those be data privacy issues or biases that may exist within data sets. But in my view, a key thing to keep in mind at this point in time is that AI is still being used very much to assist clinicians, not to replace them. But of course, there will continue to be a lot of discussion around how that may change over the years to come.
So as Holly said, AI is not new. So I think it's interesting that the insurance market calls it an emerging risk. I think those in the healthcare industry would refer to it as an evolving risk, because it's always been there for a long, long time. We've had lots of algorithm technology, radiology, brain scans, virtual wards, that's, again, like Holly said, assisted us in delivering outcomes. So I think it's looking at the clients that bring AI in to see as, okay, how are they using it to complement their safety? So again, assisting them. If you think of the Swiss cheese methodology for incidences going through the gaps in the protocols, is making sure that the way that they deliver their AI is supportive, that there's always a human element, that they're not relying heavily on it. And again, regulation. So for me, regulation is the biggest concern, as a lot of countries are finding it really difficult to regulate, especially, like Holly said, when you've got cross jurisdiction. But the other side of that is you will have innovators. So you will have clients who will be doing something new, and who will be bringing in technology that seems quite risky. So someone at some point has to explore these risks for us to keep developing. So it's about keeping an open mind and knowing the limitations that can exist. So fantastic, thank you. I think we're finished with our present. Oh no, sorry, back to Holly.
So how does all of this impact the underwriting? In summary, clinical risk insights and advice has a huge positive impact on the underwriting process. So by engaging with our risk engineers like Stella, we can have a better understanding of clinical factors, and that can in turn influence opinion on risk and the rating factors that we use to ultimately price our insurance programs. It can also provide us with a much better understanding of individual claims, or allow us to form a view on claims patterns and trends, or perhaps even more importantly, form a view on some of the underlying factors which have contributed to claims and could in fact indicate a wider issue with how a healthcare provider is actually operating. And these factors collectively influence the coverage that we provide under our insurance programs, whether that be the limit of indemnity, the premium that we're charging, or the specific policy terms and conditions. So ultimately, this means that clinical risk input can positively impact the overall underwriting results. Again, that could be achieved through improved client retention rates or conversion rates for new business prospects, better loss experience, or a more accurate understanding of exposures. And I think most importantly, this ultimately allows us to achieve better outcomes for all parties that are involved in the insurance contract.
Thank you. So
Thank you.
I think we've finished presenting now. I don't know if there's any questions.
Thank you, Stella and Holly, for that very insightful presentation on the clinical aspects of healthcare risk. At the moment, we are open for questions. So if anyone has any questions, feel free to put them in the chat box, and Holly and Stella will be very happy to answer that. I think to begin with, I would like to ask first, maybe a major three key takeaway from the presentation from each of you, Holly and Stella.
I think for me, what I've learned is with the underwriting is you can be comfortable in the patterns of the things that you underwrite. So I know that I feel like if you see reoccurring risks or it's a regular part of the business, is you've got an appetite for that, but it's having a sense check of that individual proposal. So I think sometimes, even if it is with an appetite and it's something you do regularly, is occasionally having that stopgap to check, has anything majorly changed within that space. And I guess birthing is probably the biggest example for us, wasn't it? Because we I know when I came on board, it was birthing pools weren't popular, and a lot of our clients don't necessarily have them, but now we kind of have a different view on it. Okay, you've got birthing pools, but tell us how you use them. So there's still there's still caution there, but it's more open to, okay, we're listening, let's just work out how you use them. So I think definitely for me is have a stock check on things that you do regularly. Oh gosh, that was just one thing, but Holly, I don't know if you've got.
Yeah, I don't know about three takeaways, but for me, I think, hopefully our presentations demonstrated just how much value add having access to real clinical expertise really brings to the underwriting process. So there's obviously lots of factors that actually it can influence, but ultimately I think a big part of that is really how we connect with our clients. Stella's so invaluable in client meetings, and really it has a huge positive impact on how we operate, really. Yeah.
Thank you very much. And one more thing for me, how do you think AI, because it is a very interesting angle that we're looking at here, and how do you think AI will impact the future of healthcare risks?
I personally think there is a risk that over time clinicians could become over reliant on AI tools and potentially start to become de-skilled in a way. I think that's a huge risk for the healthcare sector generally. And I think it'd just be really interesting to see how the benefits of AI weigh up against those additional risks as it
Mm-hmm,
continues to evolve.
mm-hmm,
Yeah, and just adding to that, I mean, if you think about the Da Vinci robots, so this is surgery that people are used to using their hands and their muscles. And, you do build muscle sets. So if you speak to any orthopedic surgeons, they're usually quite strong and they have specific muscle sets to do with the work that they do. And obviously, if they had a period of time off, they would have muscle wastage and fatigue. So if your robots are doing a lot of the work for you and then you have to step in, is it your skills have reduced, but your physical ability might have reduced as well to deliver that. So that's for me a perspective to think of. And also, yeah, again, it's the reliance. So we see that now with telemedicine. Actually, is there's a lot of use of telemedicine, video consultation, and sometimes the evidence is saying this added to the appointments. It didn't remove the barrier because you have an online video appointment. You can't see the whole patient. You're not getting a perspective of how unwell they are. And as a clinician, you think any doubt, okay, I need to bring you in, and that might actually add to it
mm-hmm,
more than take it away. So I think there's the risk of certain things adding. And for me, I guess the last concern is some of the AI will be driven by necessity, as in we have no other choice. So if you look at remote radiology, there is not enough radiologists. So we are forced to change the way we work because we don't have the resource, we don't have the staffing. And that actually presents a problem when you're forced into that space. So if you look at the pandemic, a lot of us were forced to do video consultation because we couldn't do face to face. And that did actually, the evidence is showing that caused a lot of problems. I mean, that was an emergency situation. So obviously it was rolled out with no real training, no real sort of thinking about safeguarding. We were learning on the job, but at the same time, some of the AI that we'll see coming through will be forced through because we just don't have the resource.
Mm.
Thank you. Thank you, Holly and Stella. And we have one more question here. With the increasing use of AI in diagnosis and treatment recommendations, what is one potential risk for patients and how could healthcare providers mitigate this risk?
Ooh,
I think
I
it's a
guess
great question.
Good
So,
question.
it depends on, so some of the AI depends on the patient contributing. So for me, again, that comes back to patient selection. So if you have a patient that is a poor historian or is not able to describe their symptoms in a way, so at some point where we have patients contributing, if you think we use it for other things where you have a chatbot, and you put in some words and then the algorithm searches for those words. However, I'll see it in healthcare, people use very different expressions and terminologies for parts of their bodies or their symptoms. And so therefore, until you've got a way to recognize the different way that people describe how they're feeling. And also, if you look at some conditions, you present with physical symptoms, but it might be a mental health implication. So I guess that's a big risk for the patient, is when the AI requires their input to put in their symptoms, as in, if those algorithms don't match up, then you're going to end up with very different diagnoses or treatment plans potentially. So I think that's a huge risk for the patients, is that not being
yeah,
able to understand them.
I think all the time that AI continues to assist in the diagnosis process, I think the outcomes will be more positive for the patient. But as it evolves over time, and there could be more it's almost acting autonomously to make the final diagnosis, I think those additional risks for the patient start to arise. So if there are biases within the data set that the AI is trained on for certain demographics of patient, for example, that will absolutely increase the likelihood of an incorrect diagnosis being made. So.
Thank you very much. Thank you, Holly and Stella. And if there's any more questions that we have not addressed, feel free to reach out to us after this session, or you can email Lloyd's, and we will address them separately. All right, I believe we have come to the end of our presentation for today. We would like to thank our brilliant speakers today, Holly and Stella, for giving us very insightful sessions on the clinical aspects of healthcare risk and giving us all these very good examples. And thank you to everyone who joined us today. Please remain until the end as I will be presenting a showing QR code for feedback. And thank you. We look forward to seeing you in the next session next week on product recall and liability on 16th of July, same time. And have a nice day, everyone. Thank you.
Thank you.